Good morning, everyone. Thank you, Dr. Marshall, to actually introduce me and going over the United States TMA Consortium. My name is Satheesh Chonat. I'm an assistant professor with Emory University and AFLAC, Children's Healthcare of Atlanta. I'm here to talk about congenital TTP, some of the updates in treatment. Next. These are my disclosures. I consult and also receive research funding from these pharmaceuticals. Next. So what I intend to talk in the next few minutes is what is congenital TTP, and then we'll discuss a little bit about how it is actually diagnosed and some of the triggers with regards to congenital TTP, and then we'll jump into the treatment strategies for congenital TTP. As you may all know by now, that the major deficiency in TTP is this protein or enzyme called ADAMTS13 that's missing. And this enzyme, is shown here like a scissor, actually cleaves this sticky protein called VWF, or von Willebrand factor protein. And in patients with TTP, this deficiency results in the accumulation of, as I'll show you in the next slide. Sorry that there is a short delay in the slide movement. So here I've shown two different blood vessels. On the top is normal, and the bottom is what we see, the blood vessels seen in patients with TTP. As shown here at the top, this ADAMTS13 protein results in, if present in normal amounts, actually helps to cleave or to chop off these platelets, which are shown in these white oval to the sticky von Willebrand factor protein. So the idea is that they go into smaller pieces, and so they do not block the small blood vessel. But in patients with TTP, whether congenital or with immune-mediated TTP, there's a deficiency of this ADAMTS13. And as shown here, these sticky platelets to the von Willebrand factor accumulates over a period of time, as shown here, resulting in these microclots. And as the red blood cells go through the blood vessels from the left to right shown here, it results in the breaking of these red blood cells, what we call as schistocytes. So three main things that we tend to see in TTP. The top two are the low platelets. As you can imagine, they're all getting consumed in those little microclots. And second is the breakdown of red blood cells, what we call as hemolytic anemia, with the schistocytes, or those broken down red cells. And combined, these can result in organ injury or ischemic organ injury due to the lack of blood supply. Next. And so the diagnosis of a TTP in general is definite when the ADAMTS13 activity that we measure using a laboratory test is when it's less than 10% of normal. So we say TTP is confirmed. And then we go to the next step to understand what could be causing this. Is it congenital TTP, or is it an immune-mediated TTP? As you may have heard about antibodies before, the antibodies are proteins which can actually attack one's own cells. And that these antibodies are directed towards body's own ADAMTS13, thereby it makes it inefficient. So in immune TTP, the body does make normal amount of ADAMTS13, but they actually get attacked by the antibody. So if we look for this antibody level, so they're positive, we call it immune-mediated TTP, which is the majority of the patients with TTP. In a small amount, about 5% of TTP, what's called as congenital TTP, we do not see these antibody levels. And of course, we recommend confirming congenital TTP by genetic testing of this ADAMTS13 gene. Next. So what happens in real life? Because these tests result ADAMTS13 can anyway take from few hours to sometimes few days. So for that reason, we actually want in anyone who comes in with this low platelet count and the breakdown of red blood cells are causing hemolytic anemia, we look under the microscope to look at evidence of that, and they sometimes may or may not have any organ injury secondary to those changes. So the idea is to be send off the testing, and what we recommend is to start treatment immediately, because as we all know that this is an emergency, and if left untreated, it can be potentially fatal. Next. So as you may know, the patients with congenital TTP who are born with deficient ADAMTS13, but not every one of them actually may have symptoms. And we believe that there's major triggers where they actually seem to present for the first time. About 30 to 40% of those patients with congenital TTP can present during the newborn period, meaning usually right after birth, but they can present with severe jaundice because of the massive breakdown of the red blood cells, in addition to the low platelet count. And some of these features can just mimic a severe infection or a sepsis. Therefore, it can go unnoticed or may not get picked up. The other group of patients who may actually present for the very first time with features of TTP are those who are pregnant, as it does increase body inflammation and slightly increases the risk of TTP. Similarly, there is other group of patients who may present during infection or surgery or whenever there's other stressors that could actually result in the congenital TTP. I'm sorry that we are having some technical issues with the slide. So patients with congenital TTP, in addition to be presenting with um, um, during those periods, as I showed, such as newborn, pregnancy, or during periods of inflammation, they can present anywhere from newborn period or up to age 70 or 80 years of age. That's what various studies have shown. So it's important to be intuitive and think about conditions or symptoms that they may present, which, if it does not fit a clear diagnosis, then we recommend providers to think about TTP. And that's what the data have shown, and that's what we routinely teach our hematologists and our trainees as well. So what I'm trying to show, the slides brings up, is that there's several triggers that we see in patients with TTP or symptoms. And some of the symptoms can be mild headaches. They could present with recurrent abdominal pain, and they could present with intermittent low platelet count. They could also sometimes present with stroke or TIA. TIA is transient ischemic attack, is when these patients actually have symptoms of stroke, but they usually disappear within 24 hours. So in those patients, especially if they also have a low amount of platelets, then it's important to think about a TTP being a potential cause. Just hold on here for a second to see if you can get some slides up. Which one should I go to? Yeah, we apologize for this technical challenge. So this slide talks about when should we really consider also diagnosis of congenital TTP. So some of these patients may actually not have all these symptoms, but it's important that in patients who have some symptoms such as this could actually have congenital TTP if they, or rather consider working them up for congenital TTP if they do not fit any other diagnosis. So I've listed some of the symptoms or issues such as pregnancy losses or unexplained lethargy and abdominal pain in patients who may have a lower platelet count. Next slide. So as we were talking earlier, some of the challenges, next slide, please. Some of the challenges that we see in the diagnosis of TTP is because TTP in itself is very rare, and congenital TTP is even rare, seen in about up to 2 cases per million people compared to the immune-mediated TTP is certainly seen in much higher proportion. And pediatric immune-mediated TTP is even rarer than the adult immune TTP. So for these reasons, while it is very rare that we could actually go through entire medical training and practice without having ever seen a patient with TTP, so it's important that we continue to educate our providers and patients. Next slide, please. We discussed this earlier. Can go to the next slide, please. The onset vary from early as newborn to 70 years. So this is the data that was shown by the TTP registry from England. So they looked at about 15 to 20 years backwards, and they published this a few years ago, where we know that the immune-mediated TTP typically peaks in about 30s and 40s of age, whereas congenital TTP can be seen in any age group. I've shown here, and I've circled that with green squares, is that shown here. There's two groups of patients who tend to be seen as the neonates, or the ones in newborns, about 40% of them, and another 40% of them seen in pregnant women. But again, it's important to recognize that this can happen anytime from a newborn to a much older age group. Next slide, please. So the next few slides, we'll talk about some of the treatments, or how we recommend managing patients with congenital TTP. We'll talk about plasma products, as some of you may be aware of, and certainly about recombinant ADAMTS13. Next slide. Plasma is probably one of the most commonly used treatment strategy in many countries. It can be used on demand or prophylaxis. So on demand is when the patients are symptomatic. As you may know, that plasma is a liquid portion of the blood, so it contains ADAMTS13 in them. So by infusing a set amount based on the body weight, we expect to increase the ADAMTS13 quite quickly. But it's important to note that it will eventually come back down about 5 to 10 days after the infusion is done. So certainly people try to do this as and when needed if they have symptoms. A majority of us actually like to recommend a prophylaxis, meaning that we use it on a regular basis. But 60 to 70% of all congenital TTP patients in major registries are on a prophylaxis and a regular infusions, where they come in every 2 weeks to the hospital to receive plasma. As mentioned earlier, there is a time period for a few days that the ADAMTS13 level will probably go back to the patient's own baseline before they get their next dose. But several questions remain, because in spite of these, there are patients who have persistent organ damage, which may affect kidneys, heart, and other organs. But so we still do not know, and there's a lot to learn, meaning who needs prophylaxis? Are there a set group of patients who, why do they actually present, first of all, during pregnancy or later in life, or why not everyone present as in the newborn age group? And if they're present, how often do we give plasma? Do we give it to them every 2 weeks, every week, or every 3 to 4 weeks? How should we use platelet count or ADAMTS13 levels as a way to guide the management? We do not have answers to many of those questions, but so there's a lot to learn. Next slide, please. This is a plasma-derived factor called factor. It's the two different medications available. In the United States, it's called COVADE. In the United Kingdom, it's called BPL-8Y. So this is primarily designed for those with hemophilia A, where they have a deficiency of a clotting factor 8, have shown in Roman numerals 8. But they also contain a small amount of ADAMTS13. So they have about 9 units of ADAMTS13 in COVADE, and a smaller amount in the BPL. What's used in the United States in few patients is the uses for prophylaxis. And they give it in a dose of 30 to 50 units per kilogram. And the range of this given, again, seem to vary quite a bit, between about twice a week to every 3 weeks. But it's important to know that after this infusion is given, the level goes up again fairly quickly, but it usually comes back down about 6 to 7 days after the infusion. So again, the ADAMTS13 level does come back in a shorter period of time. So it may help to be used for certain smaller time procedures if possible. Some people prefer this because plasma infusions obviously comes with pricing. They have to go to the hospital every 2 weeks. There's certainly a significant risk of allergic reactions. And some of the advantages of this is that it's a smaller volume and can be done at home. As you may know, that majority of patients with hemophilia receive factors, replacement factors at home. And certainly it has less allergic reactions. Next slide, please. Recombinant ADAMTS13, so the manufactured protein that is artificially made, and that is actually going through exciting clinical trials. The phase 1 study, as you may know from several COVID vaccine studies, the phase 1 study is primarily done to see, one, is it safe, and two, is it well tolerated? What I'm showing here is the data from 2017, where they actually injected one dose of different doses um, to 15 patients with congenital TTP around the world, and they noticed that there was an immediate rise in ADAMTS13 level within few hours, about 4 hours or so, and they monitored them closely to see if they responded to it and if they had any side effects. And it was well tolerated with no serious adverse events, but again, it was just one dose. Currently, the phase 3 and extension phase 3B is ongoing, and that is looking at safety and how well is it, how safe is it by using it for a long-term basis, and also how efficacious is it by using it long-term. So, and hopefully we'll learn more about it maybe in the next time or in the next year, the USTMA meeting. Next slide, please. Briefly going to go over some of the other novel agents in TTP as a whole. As you might have heard, is caplacizumab. Caplacizumab is a drug which, as shown earlier, the platelets binds to the sticky protein called VWF, and that binds to the inner lining of the blood vessel. So by inserting something in between this platelet and the VWF, so that way the platelets actually spared from attaching and getting consumed. And this medication is FDA approved, at least in the United States, for use in patients with immune-mediated TTP. But it's not tested in congenital TTP, but it does not increase the ADAMTS13 level. And ARC-1779 was similarly studied in congenital TTP, but I believe that currently there's no any ongoing studies on that. So this is an exciting development. There's several other molecules which are in early phase of development, which may hopefully help provide some of novel therapies for patients with congenital and other TTP. Next slide, please. And this is my last slide, and I want to kind of summarize here by saying that I think at this point, for prophylaxis or to help prevent recurrent symptoms and also to potentially prevent long-term organ damage, is we have plasma infusions and the CoVate, which is the factor 8 and ADAMTS13 together. Hopefully, we will have a recombinant ADAMTS13 that may get approved, or that may the phase 3 studies will eventually meet their endpoints that they're hoping to meet, and will hopefully approve, and it'll be it could be potentially a game changer in treating congenital TTP and may potentially become a standard of care in the future. But it's important to recognize that this is a long-term disease, just like immune TTP, that a long-term follow-up by not just your primary care physician, but also a hematologist who's comfortable in taking care of patients with TTP. That should include supportive care on a regular basis, testing for other organ dysfunction, and sometimes also scans to look for organ damage. It's important, I cannot stress further, that the way to progress this field is, since this is a rare disease, is to ask and look for these clinical trials, as this is the only way to safely and to ensure that this drugs does truly work, or any drug. So hence, we recommend providers and also patients to actually look for clinical trials if available to participate if you're willing. With this, I would like to end my talk, and certainly Dr. Zeppa and myself will be here for discussions soon. Thank you.